Guys, thank you for outstanding presentation. That was great. We're going to follow it up with, I think this started, what year was that you presented that plenary paper? 2015? You'll probably talk about it. But Dr. Chikwe presented a plenary paper that prompted the longest discussion, second longest discussion in AATS history. The first being transhiatal esophagectomy, but who cares about that?
Right, so I've got the job of keeping you back on time and hopefully getting you to a coffee break. So 2 minutes, 2 slides to introduce 2 titans that are going to argue again about whether they should be routinely repairing 2 valves or 1. Rationale, I mean, you know, Carpentier just kind of said it all already, but essentially, generally you're not digging out a pacing lead, it's just dilatation, right? But this video is actually just quite a nice small example of just the general principles that Carpentier outlined, which is essentially that the maximum dilatation is at the posterior and the anterior annulus. You take your sutures in the septal annulus, he deliberately left a gap in the ring so that you don't harm the conduction tissues, so you reduce the risk of pacemaker. The commissures are generally where he advised sort of bigger spacing on the annuloplasty sutures to really kind of reduce it, and the ring goes in beautifully, very easily. It's about 10 minutes when you're sort of open chest. It's maybe a little bit longer on the robot, but not a lot, very straightforward, easy repair. Now, there has been a fair bit of debate, 40 years. I was asked to summarize it in about 60 seconds. I was in a little bit of a panic, but then I found on my computer in the sort of back of the hard drive, 60-second video. It was actually for the conclave in 2017, so it says New York and it says the conclave instead of Toronto and here, but here.
If everyone can sit down, we'll start the debate momentarily. Please take your seats. If I can have David Adams, Dr. Chikwe, here we go. Yeah. I think David might be afraid of the debate.
I guess Dr. Adams is running away. Joanna's gonna have to. Oh, here come Dave.
We're gonna leave. Joe, are you gonna sit with us, or are you gonna do it?
Well, whatever you like. I'm totally happy. So where were we? Oh yeah, the debate. Can we have the debate slide up? Right. So 60 seconds, 40 years of literature, about 8 meetings, and a lot of frowny faces.
This is my
Very well done.
In Steve Bowling's immortal words.
Joe, that was fantastic. I think that makes me Tina Turner for some reason, but
Okay, I love that. That was very fun.
It was fun.
You want to go first? You want me to cook you right now? Whatever you like.
I'm gonna be very brief. Can put to my slides, David. What is
Okay,
his
you go
squeezer?
first.
Next
Oh,
one.
wait, that's my slides.
Tirone David.
No. Hold on one sec. Those are my slides.
If you go to the
We got to go to
third
Dr.
presentation.
David's slide.
Was originally scheduled for 12.
He wants to go first, so we'll let him go first.
No, mine's gonna be a minute or 2.
That's good. Mine's going to be about 4.
Let me
maybe
tell you
5.
my personal guideline. I'm a full gray hair. I've done 15,000 operations, more than 10,000 mitral and aortic valve. I can tell you the tricuspid valve is very useful procedure. for patients who have severe TR. And then if you can divide between functional atrial or functional ventricular, your results will be even better. The diastolic diameter tricuspid valve is BS. There's no better term for that. How can 4 fingers of a surgeon predict future TR? And that's how we started. I opened the right atrium, I shove my fingers inside the heart. If my finger goes through, it's going to have TR in the future. That's nonsense. That's as scientific as clean or what, you know what. We have shown that size of the annulus in diastole predicts nothing. It's diastole. Tricuspid valve closes in systole. Measure something systolic, and then I'll begin to look at you a bit more seriously. Tricuspid valve closes in leaks only in systole, not in diastole. We have published this extensively. Well, the argument went on. People didn't believe me. Oh, let's do a randomized trial now. Guess what? The size of the annulus meant nothing. And those patients who had no tricuspid regurgitation but the annulus of 40 or more in diastole, 14.5 went home with a pacemaker. Pacemaker is not a benign disease. If you take a look at survival of the human beings with pacemaker and no pacemaker, it's about as short as a 3 to 4% per year in your lifespan. It's not benign. That's a serious problem. Well, not very far from here in Michigan, and my apology for those from Ann Arbor here, they published a paper. Look, I followed the guidelines, look at my results. They published this. 27% of the patients had no TR before the operation. Only a year later, 7% had TR. Half of them had no TR at all. So the surgeon is giving the patient TR with an annuloplasty. Why should the diastolic diameter of the tricuspid valve predict future TR? It doesn't. Chronic atrial fibrillation, older age, dilated right ventricle, in moderate or severe TR predicts future TR after a left side valve operation. The Americans woke up, they read my papers, and they changed the guidelines. If you take a look at 2022 guidelines for heart valve disease, look at the second paragraph here. In patients with progressive TR, progressive, they didn't say no TR, undergoing left side valve surgery, tricuspid valve surgery can be beneficial in the context of tricuspid dilatation or prior symptoms of right side failure. Their opinions are more stubborn. They kept in their guidelines. If you can put 4 fingers inside the heart, do tricuspid valve repair. Makes no sense.
Jesus.
Yeah. I want to get a watch like yours. You said that was 2 minutes? That was a lecture.
No.
Yeah, like I said, I want to get your
2
watch.
minutes.
You should need to wind that thing. Look, let's put my slides up. Tirone, I can't believe we're doing this again. It's so much fun. Can you find my slides again? Make sure the sound's up. This is great. You got to see the beginning of this anyway, just to date all of us.
Next paper is entitled Positive Impact of Concomitant Tricuspid Annuloplasty on Tricuspid Regurgitation, Right Ventricular Function, and Pulmonary Artery Hypertension After Degenerative Mitral Repair. It's from the Icahn School of Medicine at Mount Sinai, and will be presented by a new member, Dr. Joanna Chikwe.
Can you imagine that? New member of the ATS. I love that. Okay, we don't need that. But what we do need, we don't have time to have really fun, which is to show you how preposterous the debate was. Mark said it was the second longest one after the discussion, but it was really great fun. But what matters is the data. Of course, Tirone is absent of data. You showed me one slide of one data point, as opposed to, I'm amazed you didn't mention this paper. Do you see the journal? It's actually a pretty good journal. Oh, it's Joanna's paper. That was the data. That's what we were talking about at the ATS. And what this was we weren't drinking the Dreyfus Kool-Aid all the way, but we were looking at the literature and we were saying maybe that makes sense. maybe it's not always predictive, back to Brunwald's days, that if your RV's dilated, or if you have decreased LV function, or if you have atrial fibrillation, or you had moderate TR, or even mild to moderate TR, and you didn't tell me how you grade it when you do. Are you diuresed? Is your pressure high? Is it low? Have you treated the pulmonary hypertension? So there are a lot of variables when you tell me no TR. I can probably make anybody have no TR if I bring them in the hospital and diurese them carefully for 4 days. That doesn't mean they're not going to have TR one day. So we had a little bit different idea. And this was what we thought. Okay, we're going to go do a different way. If you have nothing, you have a normal tricuspid, you have no risk factor to develop tricuspid regurgitation, you get nothing. And if you have anything, you're getting an annuloplasty. You're also getting one that's careful, that will not create pacemakers. That is one of my favorite topics, and wish we had that debate going on. There are no pacemakers. That was our pacemaker rate, and I think you can see the numbers of patients. It wasn't like 20 and 30, and let's report in 30 days. It was 650 patients, consecutive patients. And remember, there was 2% pacemaker rate. You do uncover sick sinus, by the way. These patients also were having Mays procedures. And I want you to look at the number of patients that got the tricuspid repair versus the one that didn't. Remember, to get nothing, you had to have a perfect tricuspid, no risk factors. But then we did the 5-year follow-up. That was actually the freedom from moderate or greater TR. Interesting, wasn't it? The patients that didn't get a tricuspid ring actually did worse than the patients that got a ring, despite the fact they had no risk factors. So again, Tyrone, let's look at all the data. How do you explain that? You'll have a chance in a minute. Systolic pulmonary hypertension. Again, notice the normalization, the high-risk group versus the low-risk group. And again, I go back to that morbidity slide, 0.0 morbidity with this therapy. Here's the right atrial area. Again, we normalize everything. And remember, this wasn't randomized. This was, the blue group was cherry-picked for perfect, and the red group had risk factors, and the RV function, the same story. So yes, it was kind of convincing to us that we were onto something. And I'll just say as an aside, we have the lowest mortality rate in the state of New York. They published that. That's New York State Department of Health. You can look it up in a year by surgeon and by center. I don't know why we do, but one of the reasons is because we never have tricuspid regurgitation in our ICUs. We never have hepatorenal syndrome. We always have forward cardiac output. We never have to wait and it gets better over 3 or 4 days. We eliminate it. This generated a lot of debate. You saw this is a great title, isn't it? Because you could see the centers that were all arguing about it at this point. It really did generate a gigantic discussion.
Because the cardiologist from of the early group took a look at the same thing. And
this is a year later. He won't let it go.
It's like in Toronto, like a Mayo Clinic, like a Cleveland Clinic. It's rare. And big annals predicts nothing. Thank you.
This is the debate at Conclave, 17.
I guess I'll ask David the first question. David, why would you do tricuspid reconstruction in a patient with FTR?
Well, I'm going to show you. You guys got a picture up here for me? I'll let Tirone and Hartzell comment. See if it'll work. Now that's a patient that doesn't have TR. Tirone, you tell me it has a big degenerative valve, big Barlow valve. Well, that's the tricuspid. It's 5 centimeters in diastole. It's not leaking. And do you want that valve, everyone in this audience, or do you want that valve for the next, you like to tell me 40 years. Which valve do you want for the next 40 years to trust? And that's the visual argument. I think that's a normal valve. That's the valve I want the next 40 years. And we heard yesterday in the talk about percutaneous tricuspid annuloplasty trial line. You weren't here. Interestingly, I think they've done 17 patients, 60% of them had isolated mitral. Now they have severe TR, they're not operable anymore. So I think that, yeah, my first bias and the reason we got aggressive so many years ago, one was we read Dreyfus's paper and started to think maybe we should do that. But also, we were doing lots of reoperations for tricuspid disease, and lots of those patients that had previous mitral surgery. So I think it goes back to what Mark said. In his talk about robotics, which I really liked, if we can do it really safely, and we don't think we're going to increase the morbidity for the patient, and we certainly are within the guidelines. Don't forget, I have the guidelines on my side, and those guideline committees, they don't just put things in there about intervention, randomly. These are incredibly high bars that they cross to do something to someone. And this guideline, the guidelines I'm aware of, recommend intervention for normally functioning valves that have the type of anatomy I just showed you. So,
And I noticed that day, it's amazing, isn't it? After the presentation, he gets on the stage and he screams at us that we don't need to do anything. But then his first editorial comes out, now he's starting to do it. Right? Before then, nobody needs it. But then suddenly people start needing it. Now, if you have a rheumatic disease, atrial fibrillation, that changes your right ventricle. And now you can have smaller valves and tricuspid dilatation. So now we're left with, you don't have AFib, you don't have rheumatic disease, you don't have a bad RV, and you don't have a Barlow valve. Everyone else I put a ring in. It sounds like, Joe, you made a very important presentation and publication to me, because Tirone, you were changing your tune by then. And now let's examine his paper. I mentioned this earlier. This is a very important paper. It's the longest term follow-up I'm aware of in the mitral literature. And this is, again, I guess your theory that you do everything so well, if you put your hands on them, nothing happens to anybody. But thank you for publishing this paper, because this paper was important. Wow. Your tricuspid regurgitation rate's pretty high at 20 years. Let me ask you a question, Tirone. Do you think your patients would have developed that degree of TR if they'd all had a normal annulus and their leaflets were coapting deeply, not big circular valves that you left alone? I don't think so.
Would you imagine the annulus? And besides, all my reports, I consider moderate dysfunction as failure. 99% of this patient, only 2% has severe TR in this paper. I mentioned it in the text. You skipped that part.
Okay, then moderate.
So 90% is only, we don't operate in moderate TR.
I could do that too, Tirone. I notice you're better at it than I am. There's a lot of moderate to severe TR. I don't want moderate to severe TR. And that's why Ani and I wrote the editorial for that paper, reminding people that you need to treat the AFib. Jimmy, thank you. You're right. We got to treat AFib. These are the concomitant diseases. And I don't think we should leave people that are at high risk for TR progression to progress. And if you guys have never done been referred patients with tricuspid disease that had isolated mitral surgery, I don't believe it, because we still see a lot of them. And I bet you it's still the most popular, one of the most common patients that gets referred for structural therapy right now. So I do think we need to do it. I was going to skip this, but I just can't resist because you brought it up. This silly pacemaker rate of 14%. Are you kidding me? I like what Michael Chu said this morning. We're going to but let's don't blame the patient, let's blame the surgeon. You notice what happened? I led an onslaught about that paper. I was so angry about this 14%. We'd published 2% in 400 interventions. And you know what happened after that? Do you see Gammy? He was the first author of that paper. Look what happened. After that, there was an onslaught now of reviewing my own data. 3% by the author that said 14%. Immediately, Bolin published his pacemaker rate. I was sitting next to Steve when it got presented. I'm like, Steve, are you kidding me? 14% pacemaker rate? They're not my patients. Every time I'd ask somebody would tell me they weren't their patients in the trial. So now every group started publishing their own pacemaker rates. They were actually very low, which I expected. That wasn't the fault of a tricuspid ring. That was the fault of people that were doing it. And my proof in the pudding is this one. Here's the STS, 800 centers do one tricuspid a year paper. And look at the pacemaker rate, 7%, half. So no, I'm not drinking the Kool-Aid. We didn't follow the rules. I don't care what prosthesis you use. I don't care if you do a De Vega. You cannot go near where the star is. You can't. And that was a network patient that I reoperated on for mitral valve regurgitation. And I just took a video to show you, does that look like that patient might be at risk for pacemaker? He got that electively in a trial. see the fat pad, see the artery, see the suture. So again, no, I'm not going to blame aggressive tricuspid valve repair. I'm going to say you got to use open prostheses and not hit the AV node if you're going to do this stuff. Or, like Pat said, just listen to Pat at the ATS. You got to put your last suture at the level of the coronary sinus, right, Pat? I don't care what prosthesis you use. You stop at the coronary sinus. And I think, Tirone, that, you know, we don't really disagree, except for I do think that on the better part of valor, if you have risk factors, I think that we need to learn how to do a safe prophylactic annuloplasty to keep people from developing TR over the next 40 years, which is the goal.
I don't disagree. My argument is in European guidelines, and ours too in the United States, if a patient has a tricuspid annulus in diastole of 40 or more millimeter, you should do a tricuspid annuloplasty because it's going to prevent future tricuspid regurgitation. BS. There is no data. There is no information that I look at like some 550,000 papers on heart valve disease. You can Google now through Scholar GPS. And not a single paper telling you that there is echo or another objective measurement of the tricuspid annulus predicting future TR. This came from a surgeon from Paris. He shoved his finger inside the heart, and that's how it became guideline.
But I don't disagree, Tirone. But what I'm trying to say is,
No, that's
let's
what I'm
start.
saying, nothing
But
else.
let's agree with one thing. If patients have risk factors, they have a dilated RV, they have pulmonary hypertension, they have atrial fibrillation, they have a low ejection fraction. How about we just start with those patients? And
This
rheumatic
patient should
disease.
have tricuspid annuloplasty.
Thank you. You
Okay.
can see I'm making progress. If you give me 5 more years, I'll get him over the rest of this.
I should show one more paper that is in a lesser journal. A sonographer in where's the drinking beer? Munich. For the, I mean, it's true story. Went to a Oktoberfest, and you know, I don't know if you guys have been there. I've been there a few times with my German friends. When they drink, they drink. You sit down, you take 2 sausages and a pitcher of a beer within 1 hour. So now you have 4 liters of fluid, beer and sausage. Do an echo in your heart. You're going to require tricuspid annuloplasty the same day.
I'd be happy to do it for you.
There
And
you
I
go.
won't give you a pace. And Tirone, guess what? I won't give you a pacemaker.
You go in the urinal, you pee 3 liters, and TR goes away. Of course it's up. Anyhow, we should have gone on, and the discussion is going to go on. My only argument is, please remove from your guidelines the 40 millimeter is a predictor of future TR. It's not.
Yeah.
The paper from Milan, from ours, the randomized trial, and there's an increasing number of papers showing it bears no relationship. The best, where is Joe Lee? Jay Lee has, from Korea, his group has a paper. It's systolic diameter of the RV and systolic diameter of the tricuspid annulus predicts TR in the future. That's the best paper ever published. In circulation, nobody read. Oh, it's from Korea. But it's the best paper. It's the most scientific information on predicting TR. Is systolic diameter of right ventricle.
Yeah.
And-
And again, your point is right. It's the risk factors that we need to focus on. It's not anatomy more than it's risk factors. Okay.
We have to move on. I guess we'll be here all day, all night.